Welcome to our video on common helminthic infections. Let's get started. In this lecture, we will cover frequently tested nematodes, trematodes, and cestodes, which are also known as roundworms, flukes, and tapeworms respectively. Though there is much that can be learned about helminths, we'll only focus on the most frequently tested aspects of each parasite. And if you want many more details, you can go to our microbiology chapter and learn from our image mnemonics on these parasites. Here's a list of nematodes that we'll cover in this lecture. Let's begin with Enterobius vermicularis, also known as pinworm. Enterobius vermicularis is transmitted either fecal-orally or via autoinoculation. Let's utilize this figure to explain the transmission of this parasite in more detail. In essence, a person ingests embryonated eggs of the parasite, which travel to the small intestine, and there they hatch into larvae. A mature female parasite eventually migrates through the gastrointestinal tract towards the anus and deposits eggs around the anus, particularly at night. Those eggs either get shed with the stool or end up in the infected person's fingers if he or she scratches his or her bottom to relieve the itch. If the fingers subsequently make contact with the mouth, then the person may get reinfected with the parasite. Now that process is known as autoinoculation. Now the classic presentation of enterobiasis is a child with anal pruritus that worsens at night. This is because children are less likely to use proper hand hygiene, making autoinoculation a lot more likely. And the diagnosis is done with a so-called Scotch tape test, in which the clinician applies adhesive tape to the anus and subsequently examines the tape under the microscope. Now the idea is that the eggs deposited in the perianal area will adhere to the tape and will be visible under the microscope. Here's what Enterobius eggs typically look like under high magnification. The management of Enterobius vermicularis is either with parenteral pamoate or albendazole, and either of those drugs should be given to both the patient and all household contacts because this parasite is so contagious. Let's move on to Necator americanus and Encyclostoma species, also known as hookworm. Necator americanus and Encyclostoma species infect the host via penetration of the skin, and classically, examiners will provide a history of patients who were walking barefoot on the beach in order to clue the students in that there's a potential hookworm infection. Now, the high-yield clinical presentations include iron deficiency anemia and cutaneous larva migrans. Now, iron deficiency anemia occurs because the parasite latches on to the intestinal wall and feeds on the host's blood. So naturally, you'll lose blood. So iron deficiency anemia. Now, cutaneous larva migrans, on the other hand, is a specific type of rash that occurs following penetration of the skin by the parasite. Here's what cutaneous larva migrans can look like on examination of the skin. In this case, on the sole of the foot. This is a pruritic maculopapular rash, and it's often described as serpiginous because of its snake-like pattern. The diagnosis of a hookworm infection is largely clinical, although it can be supported with stool examination looking for the parasitic eggs. Now, the management of intestinal hookworm infections is either with parenteral pamoate or albendazole, and cutaneous larva migrans, specifically, can be treated with ivermectin as well. So in other words, when you're treating hookworm, you can give parenteral pamoate and albendazole, and if they also have that cutaneous larva migrans, add ivermectin. Let's move on to Strongyloides stercoralis, also known as threadworm. Similar to hookworm, Strongyloides stercoralis infects the host by penetration of the skin, leading to formation of a pruritic rash. It can subsequently travel to either the lungs or the intestines, leading either to mild pulmonary or mild gastrointestinal symptoms. And the diagnosis is confirmed with stool examination. You're looking for larvae of the parasite, and that can be supported further with serologic testing. Now, the treatment is with either albendazole or ivermectin. Let's move on to Ascaris lumbricoides, also known as giant roundworm. Ascaris lumbricoides infects patients via the fecal-oral transmission. The parasite travels to the GI tract, where it attaches to the intestinal wall and feeds on the host nutrients. Now, the primary risk factor for infection is travel to endemic regions, such as Asia. Now, most people remain asymptomatic until they develop a high parasitic burden. Now, at that point, patients typically present with signs of malnutrition, such as anemia or a vitamin deficiency, or there can be signs of small bowel obstruction and eosinophilia. Here's what small bowel obstruction can look like on an abdominal x-ray. Note the significant distension of the bowel, as well as multiple air fluid levels, for example, here and here. Though this can happen in patients in whom the Ascaris burden is so high that the giant roundworms no longer fit in the intestinal lumen, and oftentimes they obstruct at the ileocecal valve. The diagnosis of an Ascaris lumbricoides infection is with stool examination looking for parasitic eggs. Now, the management is usually with albendazole. Of course, clinicians should also address small bowel obstruction if that develops. Now, typically, a small bowel obstruction can be managed conservatively. for example with nasogastric suction and IV fluids. Let's round up nematodes with a discussion of Trichinella spiralis, also known as porkworm. Trichinella spiralis is transmitted to humans either fecally, orally, or via consumption of undercooked meat, for example, pork meat. As with Ascaris lumbricoides, the primary risk factor for contracting Trichinella spiralis is actually travel to endemic regions, in this case, Thailand or Mexico. Once inside, the parasite hatches in the intestines and disseminates via the bloodstream to various tissues and organs, particularly striated muscles, where it leads to significant inflammation. Now, patients usually present with the classic triad of trichinellosis that includes periorbital edema, myositis, and eosinophilia. Other notable symptoms include fever and subungual splinter hemorrhages, which are small, thin lines of discoloration. You can see them when you're looking at the nails, like fingernails. Now, the diagnosis can be clinical, and that's based entirely on historical clues and physical examination findings. That being said, serology and muscle biopsy are available to confirm the diagnosis, and the treatment is with bendazoles, such as albendazole. Here's what splinter hemorrhages can look like in real life. Note these small black lines on the nail here and here. Here is an image of striated muscle tissue infected with Trichinella spiralis. You can see multiple encysted larvae, for example, here and here. In children, which bacterial infection may mimic the symptoms of a pinworm infection? Okay, the bacterial infection that may mimic the symptoms of an Enterobius vermicularis infection is perianal streptococcus, which is a superficial infection of the perianal region with Streptococcus pyogenes. Both conditions can cause intense perianal pruritus and subsequent perianal erythema and excoriations from excessive scratching. However, perianal streptococcus will also present with a sharply demarcated erythematous perianal rash, as well as painful defecation and blood on the toilet paper, and even perirectal fissures. None of these features will be present in patients infected with Enterobius vermicularis. Lastly, it is important to remember that while Enterobius vermicularis can be treated with either parenteral pamoate or albendazole, perianal streptococcus is treated just like pharyngitis, that is, with oral antibiotics, as you're trying to actually attack the strep pyogenes. For example, you can use penicillin. Now that we've finished our discussion of nematodes or roundworms, now let's move on to trematodes or flukes. First, we'll discuss Schistosoma species and a parasite called Clonorchis sinensis. So let's start with Schistosoma. The transmission of Schistosoma species occurs upon skin contact with contaminated freshwater, where the parasites can burrow into the host's skin and subsequently spread via the bloodstream. The clinical presentation depends largely on the actual species that infected the host. For example, Schistosoma mansoni and Schistosoma japonicum disseminate predominantly to the gastrointestinal tract and the liver, where they commonly cause diarrhea, portal hypertension, hepatosplenomegaly, and even cirrhosis. Schistosoma hematobium, on the other hand, travels to the genitourinary system, where it can cause persistent inflammation of the bladder, leading to hematuria and increasing one's risk for squamous cell carcinoma of the bladder. Now, the diagnosis can be confirmed with stool examination for ova and parasites, and the treatment is with praziquantel. Here's an image depicting the egg of Schistosoma mansoni. Note the characteristic lateral spine that can help you identify this parasitic egg on the exams. And here's an image depicting the egg of Schistosoma hematobium. Note that this egg has a terminal spine rather than a lateral spine. Hence, unlike most parasites, Schistosoma species can be recognized based on the appearance of their eggs. Look for a lateral spine to identify Schistosoma mansoni and a terminal spine to identify Schistosoma hematobium. Let's move on to Clonorchis sinensis. Clonorchis sinensis can be acquired via consumption of undercooked fish. On exam, its clinical presentation is largely confined to development of pigmented gallstones and increased risk of developing cholangiocarcinoma. The diagnosis can be made with stool examination looking for parasitic eggs, and the treatment is with praziquantel. That's about all one needs to know about trematodes or flukes for the USMLE Step 2. Let's move on to cestodes, also known as tapeworms. Specifically, we will cover the Taenia species, Diphyllobothrium latum, and Echinococcus granulosus. So let's begin with Taenia species. Taenia species have two primary modes of transmission: fecal-oral transmission, which can lead to neurocysticercosis, and consumption of undercooked pork or beef, which can lead to intestinal tapeworm disease. Let's utilize this figure to help distinguish the two modes of transmission. You may recall this diagram used in our microbiology chapter when discussing this parasite, but we'll review it here. Beginning at the top left of this diagram, cysticercosis can occur following exposure to feces contaminated with Taenia eggs. The eggs will hatch in the intestines, then access the bloodstream and disseminate throughout the body, depositing predominantly in the muscles and the brain. Upon reaching their destination, the larvae will form cysticerci, which are essentially cysts around the larvae. When those cysticerci form in the brain, this disease is called neurocysticercosis. And when the cysticerci form in other tissues, on the other hand, the disease is called cysticercosis. So just without the neuro part. Now suppose that pork meat contaminated with cysticerci is undercooked and consumed by a human. The encysted larvae will enter the gastrointestinal tract and mature into adult worms, which will subsequently shed eggs in the stool. As a result, that person's feces will be contaminated with Taenia eggs, and improper hand hygiene may lead to transmission to another person who may subsequently develop either cysticercosis or neurocysticercosis. In some, cysticercosis or neurocysticercosis is contracted by consuming Taenia eggs, which are shed in feces of the infected host, while intestinal tapeworm, on the other hand, is contracted by consuming tissue contaminated with cysticerci, such as undercooked pork or beef. As far as clinical presentation goes, the key points to remember is that intestinal tapeworm disease presents largely with diarrhea, and neurocysticercosis presents with neurologic symptoms, most commonly seizures. Here's an MRI image depicting the brain of a patient with a severe case of neurocysticercosis. Note these intraparenchymal cystic lesions in the brain that almost give it the appearance of Swiss cheese. Because of its unique appearance, examiners do expect students to recognize neurocysticercosis based on imaging alone, so it's important to commit this image to memory. The diagnosis of Taenia infection is confirmed with stool examination for ova and parasites. You'll often hear O and P. And the treatment of intestinal tapeworm is with praziquantel. The treatment with neurocysticercosis, on the other hand, is a bit more involved. First and foremost, the clinician should address complications that can arise as a result of neurocysticercosis. For instance, by giving the patient anti-epileptics to manage seizures. Once the patient has been stabilized, the clinician can then proceed with antihelminthic therapy with either praziquantel and/or albendazole. Let's now move to the next tapeworm, Diphyllobothrium latum. The transmission of Diphyllobothrium occurs via consumption of undercooked fish. The parasite latches on in the gastrointestinal tract and slowly feeds on the host nutrients. Most patients remain asymptomatic, or they exhibit non-specific symptoms. Now, the key presentation to remember for exams is megaloblastic anemia, secondary to vitamin B12 deficiency. This happens because the parasite has a uniquely high affinity for vitamin B12, and hence competes with the host for absorption. The diagnosis can be confirmed with stool examination for eggs, or proglottids, and the treatment is with praziquantel. Let's wrap up this lecture with a discussion of Echinococcus granulosus, also known as dog tapeworm. Echinococcus granulosus is transmitted fecally orally following exposure to contaminated dog feces, and the primary risk factor is travel to developing countries with poor public sanitation practices. The most high-yield presentation of Echinococcus granulosus is a liver cyst, known as a hydatid cyst. Most commonly, it causes patients abdominal discomfort and may present with abdominal pain, and logically that would be in the right upper quadrant, and the patient can actually have hepatomegaly. In some patients, the cyst may rupture and lead to high fever and eosinophilia, and the diagnosis is actually confirmed with imaging of the abdomen, either with ultrasound or a CT scan. Here's what a hydatid cyst can look like on abdominal ultrasound. Note the normal liver parenchyma here, as well as this round cyst with smooth walls and multiple internal septations here. Oftentimes, hydatid cysts will be described as having daughter cysts inside them, which refers to these internal septations. And here's what a hydatid cyst can look like on a CT scan of the abdomen. This cyst is located right here in the right lobe of the liver. Once again, note the characteristic internal septations of this cyst. Here's another CT image depicting a hydatid cyst, but this time without internal septations. This image serves as a better example of the classic eggshell calcification pattern associated with hydatid cysts. Note the irregular white line around the cyst that somewhat resembles the shell of an egg. Importantly, examiners expect students to recognize hydatid cysts in the liver based on either extensive internal septations, as seen on the previous image, or the classic eggshell calcifications seen on this image. Most Echinococcus granulosus infections are treated with albendazole. Percutaneous drainage can be used for treatment of large hydatid cysts, and surgery is typically the best management option for ruptured hydatid cysts. A 25-year-old patient with poorly controlled HIV undergoes a brain MRI for headaches, vomiting, and seizures. Imaging reveals multiple ring-enhancing lesions. What is the most likely diagnosis? Now, it may be tempting to diagnose this patient with neurocysticercosis because imaging reveals multiple lesions in the brain. However, the lesions of neurocysticercosis are typically described as cystic lesions rather than ring-enhancing lesions. In fact, finding multiple ring-enhancing lesions of the brain, especially in a patient with poorly controlled HIV and neurologic symptoms, is strongly suggestive of toxoplasma encephalitis. It's important to contrast the imaging findings of these two pathologies because both can be acquired from consumption of undercooked pork, and both can lead to multiple lesions in the brain. Knowing this key difference in description of the lesions will help you confidently distinguish between them on exams. To learn more about toxoplasma infections in HIV patients, please refer to our lecture titled STD HIV/AIDS from the infectious disease section in our internal medicine lectures. Here's a table summarizing the most salient and high-yield concepts discussed in this lecture. You may find it useful to return to this table when reviewing common helminthic infections before your exams. Now let's conclude this lecture with a multiple-choice question. A 35-year-old otherwise healthy male is seen by his primary care provider for worsening dyspepsia and abdominal fullness over the past several weeks. He recently returned from a business trip overseas. He denies constipation, diarrhea. He denies swimming in freshwater rivers or lakes overseas. Blood pressure is 120/70, pulse is 64, and temperature is 36.5 degrees Celsius. Cardiopulmonary examination is within normal limits. Abdominal examination is notable for mild tenderness to palpation in the right upper quadrant and hepatomegaly. An abdominal ultrasound is ordered and reveals a 4-centimeter cyst with smooth walls and multiple interceptation in the right lobe of the liver. What is the next best management of this patient? A. Reassurance. B. Albendazole. C. Pyrantyl pamoate. D. Ivermectin. Or E. Surgical excision. Okay, now the correct answer is B. Albendazole. This is a case of an otherwise healthy male with a recent travel history overseas who now presents with several weeks of dyspepsia and abdominal fullness. And his physical exam is notable for the right upper quadrant pain and hepatomegaly. And that abdominal ultrasound reveals a liver cyst with smooth walls and multiple interceptations. This clinical picture is consistent with the diagnosis of hydatid cysts, secondary to echinococcus granulosis. Recall from this slide that for most patients, the treatment for echinococcus granulosis is with albendazole, and surgery is typically reserved for ruptured hydatid cysts. This is why option B, albendazole, is the correct answer. Now option A, reassurance, is not correct because the hydatid cyst will not resolve on its own. Options C and D are incorrect because neither pyrantyl pamoate nor ivermectin are used in treatment of echinococcus granulosis infections. Finally, option E is incorrect because, as we were reminded on the previous slide, surgical excision is typically reserved for patients with ruptured hydatid cysts, which isn't the case in our patient. And that concludes our lecture on common helminthic infections.